Chapter 22, Assessing the Child and Adolescent. Child-centered care, pediatric assessment entails collecting data in a variety of ways. Family-centered approach is essential, and we need to respect cultural differences and really develop a relationship with both the child as well as the parent. And it's important to develop a rapport with the child so that the child can be trusting of you. Data collection is just with a newborn. It's collected from a variety of different sources through observation, diagnostics, health history, as well as a physical examination. The developmental principles can be received from the American Academy of Pediatrics, which identify 5 stages of development. Understanding that there are many events in a child's life that may impact growth as well as development. Normal physical growth advances in a sequential and predictable path. Development is directional, and Tanner scale is what is used to describe their stages of physical development, and all children and adolescents follow the Tanner stages, but at levels on their own. Diagnostics include a urinalysis to identify infection, hydration status, hematocrit to determine if they're anemic, blood levels, lipid screening, infectious diseases, and tympanometry. Again, child-centered approach. What brought you in today usually is a good start of question to identify what's going on when you first receive the child. And their health history can be encompassed by their birth history, their past medical history, any family history, siblings history, psychosocial history. That's where do they live, how do they live, where do they go to school, are they using social media, how often, frequency, are they playing any sports, are they at risk for any trauma, are they using any smoking or substance use or abuse? And we'll go over the CRAFT questionnaire. And are there any behavioral issues that the parents have? What does their sleep history, nutrition history, and elimination history look like? We also want to collect information about their general health and review of systems. Specific for the female gender, we want to ask about any breast development, and then for the male as well as the female. And with the male, we want to ask them about any gynecomastia. We want to ask about male and female genitalia and genitourinary function, sexual activity, signs of abuse, sexual orientation, and whether or not in the adolescent population they're doing any self-examinations, breast exam as well as testicular exam. We want to ask them about their musculoskeletal and neurological systems. Headaches can be common in children along with abdominal pains. If they play contact sports, have they, are they at risk for concussion or contusions? And then the endocrine system, we all want to assess for comorbidities such as hypertension, diabetes, any changes in growth pattern, delayed sexual maturation, or precocious puberty can indicate any puberty issues. Children will feel vulnerable when they're exposed, so we always, number one, want to develop a rapport with them, and we want to approach them. Table 22.4 is a great table to determine the type of approach you would take based on their developmental level. Parents of older school-age children or adolescents should leave the exam room to provide privacy. You should always ask for permission to assess private areas. Use age-appropriate, non-medical jargon for explanations, and try to keep the room warm, free of any drafts, and keep the room private, helping to maintain their dignity. We'll obtain our general survey of the patient. A normal survey will include good hygiene, normal clothing, normal attire, normal posture, eye contact. They're alert, they're cooperative, they have normal musculoskeletal as well as neurological coordination. And they demonstrate positive interactions with you. We want to collect anthropometric measurements, height, weight, and their vital signs, and pain scale. Assessing weight and placing that on their growth curve to make sure that they are trending normally. When we're assessing their weight, we're asking them to stand independently. Children 36 months and older can actually be weighed on a standing scale. Any child less than that can be placed on a tabletop scale. And they should follow the trend, normal weight in child. Anything that is lower than the 5th percentile for that child's age or greater than could indicate an issue with their weight, diet, and something we might also look for other comorbidities. We want to assess their height and plot that on the curve. If they are able to stand, we can use a length board. If they're not able to stand, we can actually have them laying down and measuring again from head to their heel. If you're using a length board, gently hold the head in midline, firmly press on both knees to fully extend both legs, and again, legs should be fully extended, and you're documenting in centimeters. When you're assessing their height, make sure that you remove their shoes and place their feet together. Familiar short stature, temporary delay in skeletal growth can be normal, so you always want to look at the parents as well. Are they tall? Are they short? When assessing temperature, we can use the tympanic or the temporal. We can use their axillary, oral, ear, forehead. Again, rectal is probably the most accurate, but we defer rectal for those who need to have a rectal if we're questioning their temperature or if they're in the hospital. Rectal is usually more traumatic, more invasive. Tympanic may be used in infants 6 months and older. And temporal thermometers are accurate for children as young as 3 months. And that probably is your easiest one if you have one accessible. You want to assess their apical pulse. And as they get older, their pulse does slow down. So infants usually 80 to 120, toddlers 80 to 110, school age 70 to 110, and then adolescents usually drop 55 to 90. We would assess the respiratory rate as we would our adult clients by assessing for depth, rate, rhythm, and effort. They should not be retracting. There should be no grunting, no nasal flaring. Their skin should not be pale or mottled. We would also assess their blood pressure as well as their pain, and using a variety of different pain scales to assess for pain. The best method for pain assessment in children is a validated, reliable, age-appropriate tool that accounts for their cognitive and language ability. So the FLACS We can use that for children between 2 months and 7 years, since they might not be able to verbalize pain or understand how to verbalize their pain. Comfort behavioral scale assesses pain and sedation in infants and children, where we observe the face and body for full 2 minutes and document alertness, agitation, rate of respirations, crying, physical movement, muscle tone, as well as facial tone. The Oucher scale is another that has a number scale and picture, and they can determine where their ouch is on that scale. We want to inspect as well as palpate the skin and use plenty of light while we're doing this. And normal findings will include good hygiene, warm, moist, uniform color, no evidence of cyanosis, good skin turgor, no lesions. We'll assess their scalp and their hair. Look at their toes and their fingers. Their nails should be smooth, short, uniform. Capillary refill less than 2 minutes. No evidence of redness, exudate, or inflammation. We look at their face, mouth, neck, and head, assessing for shape, movements, symmetry, any facial expressions, any tenderness, asking the child to stick out their tongue, look for any symmetry, any deviations. Palpate the TMJ for any crepitus. Ask them to open their mouth, ask them to say ah. Palpate their palate, look at their teeth, identify any trauma. Note the color integrity as well as malposition or malocclusion of teeth. Assess their neck, assess range of motion of the neck, palpate the lymph nodes, look at the trachea, palpate the thyroid. Assess their ears. Assess for hearing as well. Use the otoscope to look at the tympanic membrane. Usually with the ear, you can do it in either the supine or having the child on their lap, and you're just pulling back and up for children who are over the age of 3. If they're less than the age of 3, you're pulling back and down, and that will accommodate the change in eustachian tube. And so this is a picture of how you would assess the tympanic membrane. And another picture. Normal findings should be normal tympanic membrane, no exudate, no redness, no edema. All landmarks should be visible. You'll inspect the eyes as you would. You can use also the ophthalmoscope, and there's no change in how you are performing the ophthalmoscope in the children. You can test for visual acuity. You can use the Snellen chart, also dependent on their developmental level and age. You can use different charts that children will be able to understand. And then normal visual acuity for a toddler is 20/40. For an older child, usually 20/20. You would assess the respiratory rate, no different from how you would with an adult. With the children, an anterior posterior diameter younger than 6 years is usually a 1:2, whereas they get older, it becomes a 1:2 ratio. If they're younger than 6, it's a 1:1. I'm sorry. Cardiac system, you're listening to their heart sounds. In children who are less than 7, the mitral area is located at or near the 4th intercostal space. So their heart's in the same area, it's just a little smaller. So the intercostal spaces are going to vary by a little bit. You're looking at the abdomen, you're palpating the abdomen, you're auscultating the abdomen, and you're percussing. Children who are younger than 3 usually have more of a prominent potbelly looking abdomen. When you're palpating, make it where the child is relaxed. It could be tickly for the child, so you want to try to be as comforting, and you can actually have them place their hand on top of your hand as you're palpating. You'll palpate the femoral as well as the inguinal lymph nodes, femoral pulses. And you're looking at their musculoskeletal system. You're inspecting, palpating, assessing range of motion, and then assessing their strength. And you can actually, with this, play Simon Says to help with the range of motion assessment. You'll look at their vertebrae and assess for any evidence of scoliosis. Children aged 2 to 7 may be normally knock-kneed, where their knees are closer together. Pigeon toe is most common for gait problems in children, and sometimes they will need orthopedic consults if that's the case. And then you'll assess their neurological system, looking for any gross abnormalities, level of consciousness, mental status, how they respond to your questions, performing all the cranial nerve functions, as well as reflexes. And then finally, you'll assess the male as well as the female genitalia, identifying any signs of trauma, any sexually transmitted infections, and then any abnormalities with your assessment of the genitalia. And for the male, this can include the following as discussed in the male assessment.